Hola, good morning. Christopher Proulx here. We are going to discuss mechanical spinal distraction. I wish I could be there in person. I wish I could do this live for you, but I've been traveling extensively and I'm not able to do so. So we thought this would be a good option. First, I want to thank Helder for inviting me and allowing me to share with you some of my information, and for Dr. Fukuda for providing the questions, at which I'll be covering over the next several minutes. So the way this is going to work is I'm going to provide information regarding the questions that were given to me. And I'll be breaking this down into a few different segments just because of the length of the videos and the ability to upload it. So first I'm just going to introduce myself, and that picture is not me. That's my children. I thought they were much better to look at than me, so I always use a picture of my children instead of myself. As I mentioned, my name is Chris Proulx, and I've been treating patients now for well, going on over 22 years now. And my academic background is my master's and PhD are in exercise science and biomechanics, and I did my clinical doctorate. Actually, I'm still dissertation for my PhD, and I have a clinical doctorate in chiropractic. So I'm a licensed chiropractor. I'm also a licensed sports physiotherapist, or in this country we call them athletic trainers, and I'm also a sports physiologist. So I've been a professor and research and working with manufacturers and working with patients and other clinicians on spinal distraction. So some of you may have heard me speak before several years ago. I think it was 2009 maybe. We did another webinar for your particular group. So we've been having the idea of discussing some different things and how things have changed, and in fact this was a good time for Helder to invite me to do this, and hopefully I'll be able to share with you some of the things that we've been working on, some of the things that we've been doing, and provide you some information. This is a particular interest to me for a project, and the reason is it's more of a clinical application, so I like the informality. I will be providing research background, supportive evidence to support the information that I'm providing to you. And so I don't want to just keep throwing out a bunch of research and statistics, but hopefully it will support my opinion. And that's what some of this is going to be opinion based. We don't have all the answers, and certainly from a clinical standpoint it can be a little bit different from one practitioner to the next. So the first question was, on the ideal position, and I think it was more the ideal position of the table and or the position of the patient. And that's kind of the approach that I took, was actually the position of the patient. And when we look at the evidence, and for example in lumbar, we have options of putting the patient in the supine, the prone, and the side lying position. In cervical, we can put them in an upright seated posture position. We can put them in the water. We can lie them in the supine position. Those are the typical positions that we may put a patient in. But one of the things, when I show the evidence here, is there's not a clear indication to any one position being more advantageous than the other. Now, I have seen one paper that did a comparison between a supine and the prone position, and the evidence led towards the prone position, but there were some particular issues with that particular study, and I think that when we look at the evidence overall, and there's evidence of spinal distraction that goes back 4,000 years, there's lots of opportunities to look at how we could do things differently. And I think that's always going to be a difficulty when we're looking at the different opportunities and all the different parameters that we can set for this particular application. And that really goes for everything that we're discussing with patient application. So first off is just, to look at the mechanics. There's a great paper by Lee and Evans a few years ago, and one of the things that they did was they looked at the angulation, the angle of pull. And so the angle of pull, attaching a patient especially to a line pulleyed system, or even a table system that the table can extend or flex and rotate and laterally flex. And what happens is it creates a resultant vector. So the primary vector that we're discussing is the y-axis. So it's creating a distraction to the patient in the y-axis form. And then if you add an angle, if you position the table, or in the cervical spine you increase flexion or extension, it changes the moment of pull from the spine. So it adds at least a secondary vector to that. So this was an interesting paper because they looked at changing the angle of the distraction pull on a split table design in relation to the patient's force against that table. So what was particular of interest there, and they put patients in the supine position. So that supine position, I'm going to tell you, for me, is the main position that I'm going to put patients in when I'm treating them, and I'll go over that, and it'll be for a few different reasons. But one of the things that they identified within that particular paper was, in that position you start to reduce the lordotic curve, and you open those posterior elements even before you start to impart the traction. And that's also consistent with how a lot of patients will actually lie down and sleep. And there's an initial response that's going to take place, and it will reduce the tension on those posterior elements. But what happens anyway when people are lying prone or supine is we reduce the compressive forces as a result of gravity. Now when they're in that supine position and we add an angle of pull to the table, it reduces the load of the patient's force on that table. But one of the things that I'll show you in just a moment too is it also creates a coupled motion effect, and that's kind of that secondary component to positioning a patient, whether they're prone, supine, or in that side lying. So when you add the angle, regardless of what position the patient's going to be in, it actually creates a secondary moment of pull, which could be advantageous in the reason that you may choose one position over the other. So I mentioned that I prefer to use a supine position, and it puts patients in that hook lying position. And the biggest benefit that I see for that is I can see their face, so I know what the patient is actually going to be experiencing. And also when you compare the research, the literature of patient positions supine versus prone from one study to the next, a lot of times that was relative to the device that they were using, and some devices you can only position a patient in one position. And there's a lot of data that showed very similar benefits regardless of the position, and some people certainly have their opinion based on one position over the other, but to know that we do have options. So in this hook lying position, one of the things I really like is it reduces the stress on the hip flexors, in particular that psoas major muscle. Now, as you remember, that psoas major does cross the spine and attaches to the lumbar spine. And at least in my clinical experience, I found a lot of patients that have low back pain also have hip issues. And so one of the things I like about that particular position is it starts to reduce some of the tension, the compressive forces to the iliofemoral joint. and thereby also decreases the compressive forces because of that psoas major to the lumbar spine. So when we look back at this particular position, the other thing I can do is further enhance that hip, that iliofemoral position, by putting them into Faber's position, which refers to flexion, abduction, and external rotation of the hip. And I know Dr. Foucault has done a great deal of work on the hip, and so by putting it into the open pack position, it further reduces the stress on that iliofemoral joint, and thereby allowing me to make sure that we get good retraction. And I'm going to talk about some of the other potential benefits at a later slide. And so the other thing I do is immediately following distraction is I have a series of exercises that the patient's going to perform. And immediately following distraction, and again, there's a lot of similarities to the benefits that we get. So the first indication for the position of the patient is going to be comfort. And I will never force a patient into any position that's going to be uncomfortable. So I want to make sure that the patient is going to be comfortable. So I will often eventually put patients in that supine position because of the exercise therapy that I give them immediately following. So the biggest benefit that we get is opening of that lateral canal and opening of those posterior elements even before we start to initiate traction, the reduction on the iliofemoral joint stress, and to the anterior vertebral body, and especially those patients that may have some compromise anterior to the spine, such as the abdominal aorta. We know that there's no appreciable change between the anterior vertebral disc heights. So what that means is anything anterior to that, there's also not going to be a lot of change or a lot of stress added to those particular structures. So that could be a particular reason why you may choose to put a patient in the supine position. And as we see here in the prone position, based on our table position, we can also enhance the lordotic curve. So one of the things that we get by putting the patient in that prone position is we also get further separation of the anterior vertebral body heights. So if there was a reason to provide separation in those anterior vertebral bodies, and a lot of patients there might be, it's easier to accomplish that separation in that prone position. You also get to maintain that lordotic curve if that was of particular interest to you. And you can't see it in the picture here, but one of the other things that happens in that prone position is they have to grab onto something. Now, some of our devices, so in my DTS system, and I know a lot of you have that particular system, you can use that thoracic harness, and it does work pretty well. But if they're approaching and reaching and holding on to that grab bar, it actually creates some tension in that latissimus dorsi, which may be counterproductive to what it is that we would like to accomplish during spinal distraction. So the prone position is my secondary position if I can't get a patient into that supine position. And then we have side lying. So that side lying position, now I don't have a picture of the table, of a patient on the table, but it's the same position. The belting systems for most tables are also going to be in that exact same position. And the benefit here is if a patient can't be in the supine position or the prone position, there may be added benefit to this side lying position. I typically try to put the pathology side on the table. So if their pathology is on that right side, I have them lay on that right side. Now that doesn't always happen. Sometimes if the pathology side is very painful and uncomfortable, they cannot lay on that side, and therefore we have to transition and put them on the other side. And the reason for me putting that pathology side down is I can elevate the legs and the torso, and I create that hammock effect. So it allows you to create further opening, some lateral flexion of that affected side. I also have a table that's a motorized table, so I can actually go in the opposite direction, and I can create a lateral flexion moment and opening of the lateral canal of the portion of the body that's actually away from it. So there are particular advantages possibly of one versus the other. So that side lying position can be very beneficial in patients that you can't put in the prone or the supine position, but also can be a position of pain relief, and that could be a reason why you may put them in that position. We put a pillow underneath to maintain the position of their lumbar spine. If they do need support of that, again, it's going to depend on the position that we can get them in, whether it's pathology side down or pathology side up. And then typically put something in between the knees, just as we would if they were going to be sleeping or performing a rested position. So I'd mentioned earlier that coupled motion effect. And so the added benefit of the line pulleyed system, which creates an angulation of pull, but remember that that's different than the motorized table systems. So the motorized table system puts them into a position of flexion or extension or lateral flexion and then creates the distraction force, versus the line pulleyed system, they're in their typical position whether you're pulling them with an added angle or in a straight line pull. And the added benefit of that is when we pull with the primary vector of distraction, we get the ability also to add that coupled motion effect. So for example, with this patient in the prone position, because of this angulation to it, it creates a different moment of pull, and that adds to an anterior pelvic tilt, because the way that the belting system is designed is there's a greater moment, there's a greater attachment, there's a longer lever arm closer to the table, and that's going to result in a slight anterior pelvic tilt. Now, if the patient was in the supine position, that would actually be a posterior pelvic tilt. So the benefit is we get that coupled motion effect. So along with distraction, we also get a rotational moment, which could further enhance either an opening of the lateral canal or the posterior elements if they were supine, or you could enhance that lordotic curve if they were in the prone position, or you could enhance that lateral flexed moment position if they were in that side lying position. So what's interesting when we look at the amount of stimulation, or the relaxation we should say, and resulting separation, it can be somewhat patient position dependent. So what that means is it may depend what you would like to accomplish. So now we're looking at, this is a paper by Chung in 2009, and this is a comparison between a straight line pull in a seated upright posture position, as well as having a flexed posture position where the patient is actually going to be leaning forward. So what they found was when there was that flexed posture position, they actually get a greater separation in the anterior and the posterior. So we're looking at the larger separation here in the anterior lean traction. Okay, so that may actually result in a further separation compared to what would be a more closed position, and actually would be closer to the position that you may put someone in that supine position. So this is a comparison in the seated upright posture position. And I will say that that was the first device that I used in the clinical setting over 20 years ago. But what we found was it was not always the most comfortable position. We also had to overcome the effects of gravity and potential reflexes, which could be hypertonicity or muscle spasm in the patients when they're in that seated position. So it really didn't provide us a good diversity of patients that we could actually treat. And then we also look at reducing the amount of muscle tone, and in particular the upper trapezius and the paraspinals. So one of the things that's been shown, and I use this as an example, the upper trapezius muscle is extremely strong, it's very forceful, and it's very powerful. And because of its attachments, it's really important that we make sure that we get that particular muscle to relax. Now, traction actually will do that. It induces relaxation, but if we don't do it properly, And if they're in a reflexive position where they won't relax, we will never actually be able to accomplish that. So studies have shown that the best opportunity to get complete relaxation in the upper trapezius muscle is actually going to be in that supine position. In a comparison study in a clinic setting, it's a good controlled study by Proulx et al. In 2014. So they use the typical Saunders unit, which has the patient in the supine position, and in comparison to that over-the-head door system, which is also used in the clinic setting, but the difference is patients being supine versus patients being in an upright erect posture position. And so what they found was a statistical difference between those two settings, and more benefit when you have that patient in the supine position. So I will say that from a clinical standpoint, what it does for me and applying this particular therapy to my patients is it allows me to use lower forces, because I don't have to overcome the weight of their head, and I don't have to overcome the effects of gravity. I can actually start with really low intensities, and I'm going to talk about that in a little bit. But in my cervical spine application, my initial treatments can be as low as 4 kilograms, which seems very, very low to most people. But what that does is it allows me to use very low intensities to treat a larger array of clinical conditions.